Good afternoon, everyone. Welcome to the SAMBA panel. This year, the panel is on patient safety in the ambulatory setting. We have 4 speakers lined up, including myself. I will first introduce all of the speakers, and then we'll do all of our presentations, and I ask that you hold questions till the end. The first speaker will be myself. I am Nuraja Rajan. I'm an associate professor of anesthesiology at Penn State and medical director of Hershey Outpatient Surgery Center. I will be speaking about the impact of systems-based practice changes on patient safety in the ambulatory setting. Instead of going through the entire CV of all the people who are presenting, I'm just going to do a fun fact on each person. Fun fact about myself, I always wanted to be a large animal vet, so here I am. Dr. Ehrman will be going next. Dr. Richard Ehrman will be speaking about the current state of patient safety in the ambulatory setting. And fun fact about Dr. Ehrman is he wanted to be a rock star. Dr. Schweitzer will be speaking next. Dr. Bobby Jean Schweitzer is a professor of anesthesiology and director of perioperative medicine at Northwestern University. And she will be speaking about who is too high risk for ambulatory surgery. And fun fact about her, her daughter's here currently, and she's having a really good time with her in San Francisco. And Dr. Michael Walsh will be next, and he will be speaking about meaningful use of data and benchmarking to improve patient safety in the ambulatory setting. Dr. Walsh is assistant professor of anesthesiology at Mayo Clinic, Rochester. And a fun fact about him, he always wanted to be a basketball star. So I'm going to go first. I have no disclosures. I hope at the end of the session that all of you will be able to enumerate some systems-based practice improvement strategies and discuss some of the impact of some of these strategies that are out there currently and be able to implement some of these strategies in your own practice. So I'll start with some terminologies. There's a lot of terms being thrown around. So I put up a definition list, so procedure, standard operating procedure, sets out an expected standard for performing an operation or task and may have legal implications if not followed. A protocol is just a condensed version of a standard operating procedure and can have, again, legal implications if not followed. A guideline is the ideal actions or the ideal way in which to perform a task. It's often a lengthy document and does not have legal implications if not followed, so it cannot be mandated or legally enforced. A cognitive aid is a memory aid specifically designed for use at the time when the task is being performed. And it takes into account specific rules of thumbs and places tasks in an order in which they should be performed. An algorithm is a commonly used type of cognitive aid, and it's usually a single-page document, and it's in the form of a flow chart. And a checklist is another type of cognitive aid, and it lists a suggested sequence of actions and extensively used in both healthcare and aviation industries. There are various types of checklists. One of them is the static parallel checklist, where one operator reads and performs tasks. And these are usually non-urgent, non-sequential tasks, and a good example of that would be our anesthesia machine checklist. The static sequential with verification is a 2-operator checklist. So a second person reads items and an operator confirms and performs tasks. In this, the sequence of actions is important, and an example of this is the flight deck checklist between the pilot and the co-pilot. Static sequential with verification and confirmation requires multiple team members to confirm and verify and perform actions. So a very useful example of this, which we use every day in our operating room, is the timeout checklist. The dynamic checklist enables team members to actually develop a plan using a branching decision algorithm. So an example of that would be the ASA difficult airway algorithm. So starting about cognitive aids, they have been around since the 1930s. They were first used in the aviation industry and now are being used in the healthcare industry. So do cognitive aids actually improve team or individual performance, and do they improve outcomes in emergencies? And that's what we'll get to as I present some evidence. They are condensed from extensive and detailed sequence of actions, and they are to be used while the task is being performed. Now, an ideal cognitive aid would have content derived from best evidence-based practices and existing guidelines. It should be in a format that's familiar to users, and it should have been used prior in team training. So an emergency should not be the first time that the practitioner is looking at the cognitive aid. He should have used it or trained with it prior to that. Given the nature of anesthetic emergencies, where multiple tasks are going on concurrently, a cognitive aid must support both individual and team performance. So a cognitive aid that distracts and interrupts the team from performing their tasks is actually going to have the opposite effect. It's going to actually impair team performance and may even cause patient harm. Currently, there are no formal standards for development and evaluation of cognitive aids. So a poorly designed cognitive aid has the potential to cause harm. So what's the verdict? Cognitive aids. So this is a nice review of the use of cognitive aids during emergencies and anesthesia. And the authors found that there was minimal evidence to support an improvement in team function with the use of cognitive aids, but this is only during emergencies. Cognitive aids are not commonly used during emergencies in anesthesia and appear to be not supported by the culture. So the authors found when they looked at all of these studies that people don't reach for the cognitive aid or they don't know that it even exists. The current evidence, therefore, for the efficacy of cognitive aids in emergencies is inconclusive. So how can we improve cognitive aids? So cognitive aids need to have the best clinical practice presented in the most effective order and need to be frequently updated. The important information needs to be ordered in such a way that it's attractive, it's eye-catching, and it's easy to read during a crisis. Training may improve the familiarity with a cognitive aid and enhance the chance of it being used effectively. Even if it's an apparently simple presentation like a poster or paper checklist, if you're trained on it, you're much more likely to reach for it during an emergency. A cognitive aid should be placed where it's most likely to be used. So you have an MHOUSE checklist, which is your MH cognitive aid. You should put it on your MH card or the MH tackle box. So your last algorithm, which is for local anesthetic systemic toxicity, should probably go on your block card or in the block room where you do the blocks. This is just a bar graph showing the number of publications indexed in Medline that include search terms anesthesia and either cognitive aid or checklist. And as you can see, since 2012, there's been a spike in the number of publications on these subjects. So looking at medical errors, how can we reduce errors in healthcare? By doing the right thing every time for every patient. So this was the basis of a number of checklists that were recently introduced in healthcare. Improving safety requires an understanding of the science of error and consideration of human factors, systems failures, and recognizing the need to improve organizational safety culture, and to train and avoid and mitigate errors when they do occur. So medical errors are an interplay of various factors. And because adverse events are underreported, the exact rate of mishaps and errors from many critical anesthesia incidents is unclear. Studies of completeness of preparation of anesthesia workplaces before induction found that 10 to 17% of the time, at least one important item was either missing or not functioning. So failure to check or inspect was identified as the cause in 22 to 33% of all critical incidents. And significant negative outcomes occurred in these incidents. Existing data indicate that the lack of provider competence has rarely been a major contributing factor to adverse anesthesia outcomes. Usually, it's a temporary and atypical lapse in the vigilance of otherwise competent anesthesiologists. So haste, distraction, fatigue, inattention, boredom, and failure to check have all been factors associated with preventable anesthesia mishaps in more than 60% of adverse events. A checklist is a type of cognitive aid and has been around since the 1930s in the aviation industry. Now, checklist design and implementation is very important. Checklists should be evidence-based. They should address key safety items that are often overlooked and which, if omitted, would lead to serious adverse outcomes. So checklists need to be customized. It's not a one-size-fits-all. By standardizing performance, checklists reduce reliance on memory and thus errors of omission. And not more so as healthcare processes are becoming more complex and staff is getting busier, handovers and shift working are becoming more common. This is even more important. Checklists contribute to team communication and working and increase situational awareness among team members. But successful adoption of a checklist requires careful implementation. So how do we go about that? So this is an example of how a checklist was successfully implemented. So at the Johns Hopkins University ICU, they wanted to reduce central line insertion-related bloodstream infections. So this is what they did. They picked 5 evidence-based interventions, which were recommended by the CDC, and these were hand washing, using full barrier precautions before central line insertion, cleansing the skin with chlorhexidine, avoiding the femoral site if possible, and removing any unnecessary catheters. So these were the 5 things they picked that they would change. And these 5 interventions required not a lot of equipment to implement. They had the lowest barriers to implementation, and they were also, based on evidence, found to have the greatest impact. So right off the bat, they were starting with 5 very good interventions. They went about educating everybody, and they introduced the checklist in a stepwise manner. So what ended up happening was this improved system helped maintain adherence to the infection control guidelines, and they were able to reduce, in a sustained manner, infections from a baseline of 11.3 infections per 1,000 catheter days to 0. So that's incredible. That's an incredible result from an implementation. They also had full institutional support, and they collected data after the fact. So a lot of people start their quality improvement plan with data collection, but they forget to collect data at the end, which is very important. And this checklist focused on teamwork, and the ICU nurses reported that far from increasing confrontations, it actually improved teamwork. So what lessons did we learn from this? So if you want to implement a checklist in your practice, pick an outcome that's important to your practice or that you feel needs improvement. Involve the entire team from the beginning. This is very important. If you don't involve certain members of the team, they're more likely to be negative about the change and may even put barriers to implementation. And initial data collection is important, that'll provide your baseline. And then pick evidence-based interventions that would have the most impact, and that would be the easiest to implement in your practice. Make sure you have institutional support. Make sure you provide the team with all of the equipment and supplies that they're going to need for this. Implement in a stepwise fashion. Don't go overnight and say, tomorrow we're going to be doing this. That doesn't work that way. Recruit champions. Champions are cheerleaders for your checklist. So they are well liked by their peers. They are a positive influence on any process.